All right, so important question. Audible, visible or not?
Yes, sir, you are audible and visible. Please make the slides full screen.
Okay. Is this good?
Yes, sir. Yes, sir. Thank you.
All right. Thank you so much. And thank you to Mark, Prabhash, and all the organizers for this edition of Masterclass to invite me. The topic assigned to me was first-line immunotherapy for Pdl1 positive metastatic non-small cell lung cancer without an oncogenic driver alteration. I have no conflicts of interest. Some background facts. Chemotherapy or immunotherapy or their combination, that is chemoimmunotherapy, remains the primary component of medical management of metastatic NSCLC without an oncogenic driver alteration. But it is essential to rule out presence of these driver alterations, especially the most frequently ones, prior to initiation of any form of immunotherapy. And that would include testing all patients with lung adeno and other non-squamous NSCLC histologies, and occasionally clinically selected squamous histology as well. And by the most frequently occurring ones, I imply EGFR mutations, which have a prevalence of approximately 25 to 30% in our setting, and of ALK rearrangements of approximately 9 to 10% in our setting in lung adenocarcinoma. And the reason why immunotherapy has come in such a big way is illustrated in this response to therapy. As you can see at baseline, a huge mass infiltrating into the mediastinum, loss of fat planes with aorta. And 3 months after monoimmunotherapy with pembrolizumab for this high PDL1 patient, you can see a drastic response. Again, to emphasize the point herein, the common oncogenic driver alterations were excluded by an NGS, and the PDL1 value was really high. It was 100% by sp263 and 90% by 22C3. And this was published 10 days back. Our ASCO Living Guideline panel brought out this update on both without driver alterations and with driver alterations stage 4 NSCLC management. And I will refer to these. So if you look at the algorithm which is part of this update or accompanying this update, you can see that immunotherapy really is the backbone for first-line treatment. After, again, you have excluded EGFR, ALK, ROS1, BRAF, and others for non-squamous. And as is a very busy slide, I'll go into more details. So if you talk of non-squamous NSCLC and have excluded driver alterations, you can see that if it is high PDL1, which is PPS 50% or more, it is either single agent pembrolizumab based on the Keynote 024 or 042 trials, or single agent atezolizumab based on the Empower 110 trial, or single agent semiplimab based on the Empower Lung 1 trial. Keynote 1A trial was the combination of pembro with pemetrexed carboplatin, and therefore is applicable for both the high PDL1 as well as for no expression or a low expression. Similarly, Empower 150, which was a 4-drug combination of pacli carbo, bevacizumab, and atezolizumab, is applicable to both groups of PDL1 expressors, and so is the Empower 130. Of note, you also have the dual immune checkpoint inhibitor combinations tested in the Checkmate 227 and the Checkmate 9 LA, and the Keynote 042 trial is an option for patients who are have low PDL1 positivity but are not candidates for the combination. Now, if you talk of squamous, the options are a little less. These are the same options: single agent pembro, single agent atezolizumab, single agent semiplimab, or the dual immune checkpoint inhibitor combinations. The difference is obviously that in squamous, pembrolizumab is combined with the pacli or nab-pacli carbo and not pemetrexed, as the latter is restricted to non-squamous histology. So focusing a bit more on monoimmunotherapy in PDL1 positive disease. And so this was an excellent review published earlier in JCO. Checkmate 026, which tested nivolumab, obviously was a negative trial, and we leave it out here. And so if you look at the others, you can see that if you use mono immunotherapy for high Pdl1 expressors, you get benefits in the term of much better response rates, as well as improvements in overall survival. And as you can see, the best overall survival has been for Pdl1 greater than 50% with either pembrolizumab or even atezolizumab. For cemiplimab, this OS data has not yet been reached. The improvements in PFS have been less impressive, but nonetheless, when you combine all of this into perspective, you see that the objective response rates are increased, the duration of responses are increased, PFS is marginally increased, and OS is substantially increased. Now, if you look at the combination of chemoimmunotherapy in non-squamous metastatic NSCLC, again, this is taken from that same review in JCO. You can see that there are multiple combinations which are possible. Limiting ourselves to the drugs which are available here, and that basically is either pembrolizumab or atezolizumab. You can see that Keynote 189 and Empower 150 and even Empower 130 led to statistically significant improvement in OS. The Empower 132, which combined atezolizumab with pemetrexed and platinum, combination analogous to the Keynote 189, for some particular reason, did not reach statistical significance in terms of OS benefit. And in fact, the OS benefit was the highest in Keynote 189. However, both Empower 150 and 130 also led to significant improvement in OS. Here again, response rates were better compared to the chemo-only arms. PFS benefits were again very marginal or sometimes even similar. Coming next to the combination for squamous disease, again, a very big list of all the important drugs. Again, and similarly, to restrict ourselves to what is available in our setting, it's either pembrolizumab or atezolizumab. Here, of course, it is Keynote 407, in which it was combined with, pembro was combined with carbo and pacli or nab-pacli, and the Empower 131. So now, as you can see, again, for some particular reason, Empower 131 did not meet statistical significance the way it did not meet for the Keynote for the Empower 132. For pembro, the results were very, very clear and distinct. Improvements in PFS, OS, and response rates. Lastly, about dual immunotherapy in metastatic disease. And so these are the Checkmate 227 and the Checkmate 9LA trials. It is important to remember that the Checkmate 227 was one of the most complicated in terms of a design, having a 6 arms randomization, 3 for Pdl1 greater than 1% and 3 for less than 1%. Checkmate 9LA was much simpler, in which it was the combination of the dual immune checkpoint inhibitor plus 2 cycles of chemotherapy. However, the important thing is that OS benefit was achieved in all of this. So whether it was the 9LA with 2 cycles of chemo or Pdl1 less than 1% or greater than 1%, you had OS benefits. Response rates were marginally better. PFS rates were either similar or only marginally better. Although the approval ultimately for Checkmate 227 regimen was for a Pdl1 greater than 1%, the benefit was actually, the magnitude of benefit was actually better for the Pdl1 less than 1%. Now, if you were to talk of second-line treatment, I know this is not the aim. Basically, what you can see is that if people have received first-line immunotherapy, then all what is left is basically chemotherapy, or there are no standard algorithms. However, if you talk of this in realistic terms, most of our patients do not fall in this category, and they will actually end up here because they don't end up receiving first-line immunotherapy. And the reason is very clear, that there is a very big gap between the patients who are eligible versus those who can afford. And you can look at this pricing depicted in obviously US dollars. It is phenomenal and surpasses the monthly income or sometimes even the 6 monthly income for a lot of patients. And this was a very interesting paper presented at ASCO this year by Tata Memorial Group itself, in which they showed that only 3% or less of eligible patients actually received immunotherapy. And the difference was more marked for thoracic cancers as compared to head and neck cancers. And cost is not the only constraint. This data is our data from PGI and very similar to what Rajiv showed. You can see that no expression was there in roughly around 40% or so. Very high expression was limited to around anywhere between 16% to 31%, depending upon the histology, and the rest was between 1 to 49%. And so monoimmunotherapy remains a distant dream because of either the lack of high Pdl1 expression or the cost of therapy. What are the areas of uncertainty? Well, one is the number of cycles or the duration. There is some data that continuous infusion or administration is better or has better efficacy compared to a fixed number or a fixed duration. But one has to remember that it also leads to an increase in cost. Can you do with a reduced frequency of administration? For example, doing it 6 weekly versus 3 weekly. We don't know yet, especially if you are not doing double the dose. Then what is the effect of the expanding list of druggable targets? And as we move forward, we know the targets have moved now to approximately 9. It will move more in the next years to come. And we don't know that for some of these uncommon oncogenic driver alterations, what is really the best approach? Should you use targeted therapy upfront, or should you use chemoimmunotherapy first and reserve targeted therapy later for progression? And so if you were to do such an approach, which means you use chemoimmuno early and use targeted therapy later, what is going to be the effect on the immune-related AEs? We know from the EGFR and the ALK experience that there is an unacceptable rise in hepatitis or IRAE hepatitis when you use targeted therapy later. And the third thing is, can you use this available evidence from phase 3 trials to real world setting when the typical groups which have been excluded from clinical trials are significant proportion in real world, which would mean ECOG status 2 to 3 and comorbid illnesses. And so these are still areas where you need more research and the answers are not yet defined. And last but not the least, there is no substitute for clinical judgment. This is what appears as a footnote to the algorithms in the recently published ASCO guidelines, which I was referring to earlier. And just to highlight, an algorithm is only a tool based on a guideline. It is not intended to substitute for the independent professional judgment of the treating physician. Practice guidelines do not account for individual variation among patients, and an algorithm does not purport to suggest any particular course of medical treatment. So yes, please refer to guidelines, but you have to take everything into perspective and take your own judgment. And so to summarize, first-line treatment options for metastatic non-small cell lung cancer without oncogenic driver alterations. For high Pdl1 patients, which is 50% or more, it is monotherapy with a PD1 or a Pdl1 immune checkpoint inhibitor. As of now, that would imply pembrolizumab or atezolizumab. But a combination chemoimmunotherapy can be considered for even these patients if there is a significant disease burden or significant symptom burden. On the other hand, combination of chemotherapy and immunotherapy is the standard of care for low Pdl1 expressors. But again, monotherapy with PD1 or a Pdl1 immune checkpoint inhibitor, again, pembro or atezolizumab, may be considered for those who are not fit for the combination. The clear role for dual immunotherapy, which is a combination of nivolumab and ipilimumab, remains undefined. As of now, it does not seem to offer any advantage over either monotherapy for high Pdl1 expressors or for the combination for low Pdl1 expressors, but this is subject to debate. And again, emphasizing the point, do not act upon high Pdl1 values, do not initiate immunotherapy in lung adenocarcinoma and other non-squamous NSCLC histological types. until results of EGFR and ALK testing are available and are negative. Cost of treatment remains the most important deterrent for first-line immunotherapy in low and middle income group countries like ours. And lastly, I would like to leave you with these thoughts about the impact of climate change and its impact on health, including oncology. This is an email signature of one of my friends in the US, and I was so tempted to see what all he has written that I thought it is appropriate to put it as the last slide. Thank you very much.
Thank you, sir. Next talk will be Dr. Manu Prasad. He is an associate professor in Malabar Cancer Center, Thalassery, Kerala.